All right. Good evening, everybody. Welcome to tonight's webinar session on aortic disease. My name is CJ Lee, and I will be co-moderating today's webinar session with Dr. Falls Betties from Case Western. I want to first thank the Midwest Vascular Surgical Society and the webinar committee chair, Dr. Jonathan Bath, and of course, our Angela Weatherby for their coordination and effort in putting together these great educational series. And I also want to thank Terumo for sponsoring today's webinar. We have a wonderful session on aortic disease entitled Moving Towards Individualized Aortic Therapy, Balancing Risk, Reintervention, and Repair. Now, as a housekeeping issue, I want to remind all speakers to try and stay under 10 minutes for your talk so that we have ample time for questions and discussions at the end. So Dr. Falls-Biddies and I will try to do our best to keep everyone on time. So without further delay, let's dive into our first topic of debate on management of type B aortic dissection. Our first speaker is Dr. Loïc Kabani, who is a co-director of the Henry Ford Aortic Center. He's also the Vice Chair of Research and Program Director of the Vascular Surgery Fellowship at Henry Ford Hospitals in Detroit. He will enlighten us with his view that surgical treatment of type B aortic dissection is clearly superior to medical therapy. Here are our best practices for durable, safe repair. All right, Dr. Kabani, take it away.
Can everybody see my screen?
Yes.
Okay, good. Good evening, everybody. We'll talk about surgical therapy really superior for type B aortic dissection, and I'm the pro. My conflict of interest, I'm part of the Improve AD, which is a randomized controlled trial looking at endovascular versus medical therapy for type B dissections. Dr. Crawford said no patient should be considered cured of aortic disease when they have aortic dissection. And I think that's true. It's a lifelong disease. And today we're going to be talking about type B dissections. For those in the audience that are medical students, there's type A and type B. Type B starts beyond the subclavian artery, and dissection is where the artery is split in half from a true lumen and a false lumen. And we're going to concentrate on the acute and subacute dissection because that's where it's shown that possible endovascular repair of these patients, there's some benefit. When you look at type B dissection, we have the uncomplicated and complicated. Complicated are rupture, malperfusion, and everybody's in agreement that surgery is indicated for those, but not for so much for the uncomplicated. And why is that? Why do we need to operate on uncomplicated dissections? Well, we know that there's an 80% increase in size in these aneurysms, in these dissections over time, and about 15 to 40% degenerate and become aneurysms. And the problem with degenerating and becoming an aneurysm is that they tend to rupture, especially when they reach the 7 centimeter mark. So the aim of endovascular therapy is really to cover the primary intertear, restore blood flow to the true lumen, and discontinue blood flow from the false lumen. And people have been looking at this for a while. This is an IRIDE trial back in 2007, and they looked at medical, surgical, and endovascular therapy, and there was a benefit, statistical significant benefit for endovascular therapy back in 2007. There's a more recent registry data from England looking at the type B dissections, and they saw for medical managed patients a 5-year mortality of 55% versus TBAR managed patients is a 36% mortality. So much, much better outcomes in people who are treated with thoracic endografting. Now, again, this is the registry data. It wasn't adjusted for co-founders, but it does show that there is a signal for endovascular repair. And there are some randomized controlled trials. Everybody talks about the INSTEAD trial and the ABSORB trial. Both of them showed better remodeling, decreased aneurysm-related death, but no difference in mortality. But they're small. The INSTEAD trial was 140 patients, and the ABSORB trial was 31 patients. And what's interesting about the INSIDE trial, if you look at patients who had a TIVA, 90% had the false lumen thrombosed in the chest, while only 20% of those medical therapy patients. They did a further analysis into that instead, looking at 5-year follow-up, and aortic mortality was lower, disease progression was lower, and there was a trend to a decrease in all-cause mortality. And they did some funny statistics where they readjusted the start table for 2 years. And when they readjusted the start table, there was definitely a decrease in all-cause mortality, suggesting that TIVA was better. So are there any predictors for those patients with aortic dissection that are going to expand and have a higher incidence of aortic rupture? And this is the case that, this is a patient that had a dissection. You could tell at 4 weeks it was 36 centimeters, and 4 months later it expanded quite rapidly. Well, there's a lot of literature out there looking at these high-risk characteristics: age, high heart rates, Marfan, persistent pain, and there's radiological signs looking at size of the aorta, the size of the false lumen, size of the true lumen, the intra-arterial, and so forth. And we reported at the Midwestern Vascular our findings that the degree of false lumen perfusion was also one of these signs. And the number of points. So if you have one risk factor, two risk factor, three risk factor, the number of risk factors is correlated with the degree of how fast the aneurysms expand. And look at these high risk factors. There's mild, moderate, and severe, like blood pool fusion. Everybody would say that's a high risk factor, that this aneurysm is high risk of rupturing. So these guidelines have been incorporated. These suggestions have been incorporated guidelines, and the ACC guidelines back in 2002 said endovascular management may be considered in high-risk anatomical features. Again, the class was weak, with benefit outweighing the risk, presumably. Again, this is thoracic surgery, class 2B, weak. But now in 2004, we're having stronger guidelines, and I think the European Society, the European Association of Cardiac Surgery, the STS, says it's 2A, with more than expert opinion. There is some trials to suggest that, and I think they're a little bit closer. I think the closest one is the guidelines from the European Society of Cardiology that put this as a 2A and B. 2A being should be considered with good enough evidence and data derived from single randomized controlled trials or large non-randomized trials. And as you see, as the guidelines progress over years, the recommendation is becoming stronger and stronger. So in conclusion, TIVA advantages in select patients promote false lumen thrombosis, reduce long-term complications, and may prevent needful later more complex surgery. There is a risk of TIVA, of course: stroke, retrograde aortic dissections, and complications. But I think it's becoming more standard for TIVA to be done for type B aortic dissections with high-risk features, and the data is coming more and more to show that. And we're all awaiting the randomized controlled trials, not only the IMPROVE AD in the US, but the EARNEST study in England and the Sunday trial in Scandinavia. Thank you very much.
All right. Thank you, Dr. Kabani, for that very interesting discussion. And thank you for being very timely. We're going to move on and look at an alternate viewpoint, medical therapy. Dr. Roundtree is going to lead that discussion. So Dr. Roundtree is a double board certified vascular surgeon who's currently practicing in rural Missouri. She completed her general surgery residency at Henry Ford Macomb Hospital in Clinton Township, Michigan, and her vascular surgery fellowship was done at the University of Missouri in Columbia, Missouri. She also is now serving as assistant professor of clinical vascular surgery at the University of Missouri School of Medicine, and is currently the medical director of vascular imaging at St. Francis Medical Center. So, Dr. Roundtree, please take it away and tell us about the medical therapy for type B aortic dissection.
Thank you. And being asked, I was happy to delve into this. As far as medical therapy for type B aortic dissection is obviously safer than surgical treatment. And these are our best medical practices for long-term management. So as far as disclosures go, I am a physician chief for Shockwave Medical, which is not pertaining to our discussion today. And prior to February, I was a enrolling participant for the Improve AD trial. However, I've changed tracks on there. So optimal medical management is always necessary. It's required initial management of all type B aortic dissections, and it's going to be the best long-term choice for an uncomplicated type B aortic dissection patient. So questions that need to be answered in our discussion is, does surgery or an intervention offer improved quality of life over optimal medical management? Does it improve short-term survival? Is there an increased life expectancy over the national average with surgical or interventional treatment over medical therapy? Is there increased freedom from aortic-related intervention or adverse aortic-related events? And then is it a cost-effective solution for the long-term management of type B aortic dissections? So I'm looking at the International Registry of Aortic Dissection Patients, which enrolled patients from 1995 to 2013, the 17-year data coming out. It split patients into 6 equal groups to accommodate for changes in the availability of endovascular paradigms and treatments. And I limited the conversation to 15 years backwards of literature to keep us to a more conventional discussion. Coming out of the trends out of here, the CT imaging was more prevalent for diagnosis and surveillance in later groups, opposed to more echoes and x-rays. The 1-year survival numbers, however, did not show much difference. There was a 91.9% survival after patients receiving TVAR and a 90.2% with optimal medical therapy. Aortic enlargement at 5 years, 67.2% of patients demonstrated an aortic enlargement after TVAR, with a noted 30 to 40% undergoing reintervention of some kind. 73.3% of patients with optimal medical management did demonstrate enlargement, and then 45 ended up undergoing intervention. With large data said it wasn't granular as far as the level or extent of their interventions. Treatment trends. Looking at over that 17-year period, medical management decreased from 75% of the time to 57%. The in-hospital mortality being 8.7%. Endovascular treatment increased from 7 to 31. In-hospital mortality stayed about 12.3, with surgical treatment decreasing as endovascular did increase, again with that increased hospital mortality of 17.2. Interestingly, despite the increase of endovascular treatment, there was no change in the overall hospital mortality rates or early mortality rates 30 days of the patients, ranging between 12 and 14%. So I'm jumping over specifically into uncomplicated type B aortic dissections, because again, as Dr. Fani mentioned, I think we can mostly agree that the complicated ones, life, limb, and organ ischemia, need to be intervened upon to preserve patient and their quality and consistency of life. With the uncomplicated, medically managed early mortality from a 2013 expert consensus paper, from available literature that was reviewed from 2006 to 2012, mortality of 1,480 patients of 6.4% with medical management. Stroke and spinal cord ischemia, 4.245. As you can see, the long-term survival staying similar at that 80 to 100. And then the 5 years right around 70 to almost 90%, with a freedom from adverse aortic events at 5 years of 75 to 88.5. The trending, non-statistical, not statistically significant, but trends towards safer aspect for stroke and spinal cord ischemia towards medical management versus the TVAR numbers, and then below the open surgical numbers, the increased mortality rate for TVAR increased for open surgery, as well as those freedom from adverse events. It's not zero, it's 45 to 77%, and then down in surgery, 58 to 7.7. The conclusion recommendation from their expert consensus was, in type B aortic dissections, uncomplicated, that they should be treated with medical therapy. And at present, there's little evidence of the advantage of open surgery or endovascular in the acute, subacute, or chronic phases. So jumping over to the STS and AATS recommendation guidelines published in 2021. And medical management patients with that 75 to 70% survival at 3 to 5 years. TVAR retrograde dissection happening in 1.3 to 11% with the TVAR, effectively changing a patient from uncomplicated to a emergent type A dissection for those in the audience. Also introducing a stent graft induced new entry tear in up to 25% of patients, the majority being Marfan's patients, with 33% happening, and then 3.2 reported in non-Marfan patients. Again, a class 1 recommendation of optimal medical management remaining the recommended treatment for uncomplicated type B aortic dissections. As far as asking and answering the question of are we expanding or extending out the life expectancy of patients with intervention, with surgery, the average patient is presenting with an acute type B aortic dissection at the age of about 64 years old. Folks that are coming in uncomplicated tend to be a little bit older. They have more underlying atherosclerotic disease, potentially introducing more of the flap in the first place. When you look at the life expectancy of birth registry from the World Health Organization data, peaking in 2019 and then slightly decreasing, mostly related to patient lifestyle and personal choices, we're looking at 78 years old for the average expected lifespan. At 70 to 75% still being survivability for medical management type B aortic dissections coming in at 64, living to 70, you're still within the expected lifespan. Also, when you consider the fact that the healthy life expectancy across the board, whether it's United States, the Americas, or the world, is 10 years less in all regions. So patients effectively are coming in at that point where they are living on their own. They're not in rehab. They're not requiring a significant amount of care and assistance, and they're at that healthy expectancy. Jumping over to the financial burden. So looking at the Journal of American Heart Association, it's a Canadian universal healthcare large data looking at 13.8 million patients. This was all aortic dissections, then parceled out into type A, type B, with 2/3 of these patients being type B, over 4,000 patients. Medically management is significantly less costly at the index hospitalization and the 1-year follow-up. Decreased readmission rates for medically managed patients compared to the TEVAR and surgical patients, lower imaging costs for medically managed patients, including their follow-up and surveillance. Also lower rehab costs for medical patients, especially coming out of their index hospitalization, and then the same medication costs across the board. So kind of jumping into their tables, if you will, here, looking at the index hospitalization, and I don't have a pointer, but you can see that overall the surgery, the TEVAR, the medical management, all the way over to the right, we're looking at about $6,000. And I don't need to read all those numbers to you, but again, decreased. There was an interesting aspect as far as the thoracic grafts being increased cost for the TEVARs in the age group less than 50 with an association to trauma and their overall hospital index or their index hospitalization having associated care with actually being trauma patients opposed to a isolated type B. Looking at the percentage of home care, rehab, long-term care, breaking out the folks treated with TEVAR or surgery versus medically managed. Again, less utilization of all of the resources, putting a financial burden on the health paying system, as well as putting less of a burden on the patient requiring these services. So to go back to our initial question slide of does surgery or intervention for uncomplicated type B aortic dissection, does it overall offer a quality of life improvement over medical management? Lower use of rehab after the index hospitalization with medical management would suggest no. Is there an improved short-term survival? At 1 year, there's the same rates, especially depending on which registry, which study that you're looking at, but they're just within about 5 points of each other through most. Is there an increased life expectancy beyond the national average? No, and especially if you look at it with the healthy life expectancy, even highlighting it further. Is there an increased freedom from aortic-related intervention? It's very similar at 30 to 40 versus 45% of patients. Is there a decreased risk readmission? No. Is there a cost-effective solution for long-term management of type B aortic dissection? Based on the Canadian data, it would say no, that is more costly for surgery or intervention. So that leaves us with medication. So looking at the 2022 American Cardiology Society and American Heart Association guidelines with their overall recommendations, which A little bit added in by myself here on the left-hand side versus the recommendation on the right. Your initial medical therapy is going to be anti-impulse therapy, or effectively a goal heart rate of 60 to 80 to be achieved first, so that you minimize the stress on the aortic wall and decrease the propagation of the dissection, with a goal blood pressure of less than 120 over 80, or the lowest adequate for end organ perfusion. Your beta blockers are going to be your first line agents, except for in a select number of patients. My personal preference is to start with esmolol, potentially moving over to labetalol if necessary. These are patients you're going to watch out a little bit for if you have already existing bradycardia, if you have patients that have aortic valve regurgitation, a little back and forth as far as the recent cocaine use and the potential for un, unfettered alpha stimulation. You're going to be using more of your calcium channel blockers. Adding in ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers for the hypertension. My personal preference is to utilize nicardipine as the next agent, reserving the sodium nitroprusside for refractory hypertension as a pure vasodilator. And then not forgetting about pain control. Once your heart rate's under control, initially your blood pressure is under control. Don't forget these patients are in pain, and adding the lability to the blood pressure there, you're going to be utilizing a combination of fentanyl and morphine. So ongoing management targets, goal systolic blood pressure is very similar to the recommendations for most American patients, 130 to 135. It is recommended for 30 to 60 minutes of mild to moderate aerobic exercise 3 to 4 days a week, limiting the systolic blood pressure during exercise to 180 millimeters of mercury. Also in here, notice there's no resistance training recommended, nothing with contact sports, avoiding heavy lifting or weightlifting, because that Valsalva that's created can give you an aortic pressure achieving over 300. So maintaining those aerobic exercises is more the recommendation opposed to all exercise. A beta blocker combined with a angiotensin receptor blocker is the recommendation currently, with some weak data that needs to be corroborated further as far as the angiotensin receptor blockers helping with false lumen thrombosis and avoiding the overall progression of aortic diameter. Calcium channel blockers are recommended against in the long term, especially in patients with Marfan syndrome, because of their association with aortic diameter overall enlargement. Statin therapy is recommended to discharge. It is, again, looser data, but being associated with increased long-term survival, not necessarily aortic remodeling, but overall patient survival. So references for review, and then thank you very much from our team over at St. Francis.
Wow, thank you, Dr. Roundtree. That was great. And thank you, Dr. Kabani, for your didactics today. We're going to switch gears a little bit, and we're going to discuss the pros and cons of a very beloved topic, open versus endo, for complex aortic diseases. And I want to introduce Dr. Kyler Bennett, who will lead us off with her view. Now, Dr. Bennett is an associate professor in vascular surgery at the University of Wisconsin in Madison. She's also the Associate Program Director of Vascular Surgery Residency and Fellowship. Her talk is entitled, "You Can't Beat the Stitch. Over 700 open thoracoabdominal aortic repairs have stood the test of time." All right, Dr. Bennett.
Okay. Right. If everyone can see my screen, I think. Yes. Okay. All right. So Jonathan Bath chose this title. "You Can't Beat the Stitch. Over 700 open thoracoabdominal aortic repairs have stood the test of time." So my argument will take the form of a very brief overview of the history of open repair, results of open repair, the evolution of the endovascular approach, its results. I will make an argument for the persistent role of open repair. And I posit that these are complementary and not competitive approaches. I would tell you that the open repair of thoracoabdominal aneurysms is still needed today, and we must therefore maintain surgeons and centers who can both perform and take care of patients undergoing open thoracoabdominal aneurysm repairs. So the story of the evolution of open repair, we'll start with DeBakey and the homograft replacement and clamp and sew technique that he was using in the early 50s. Etheridge came in and introduced shunts to protect against ischemia and type 4 repairs. And then Rob came in and actually started advocating for complete removal of the aneurysm sac to prevent infection, but also introduced hypothermia to mitigate some of the ischemic effects. DeBakey then came on the scene and started with visceral reimplantation. He was using shunts for distal perfusion. He was not at that time reimplanting intercostals due to this sense that there was a need to remove the actual aneurysm sac. He then introduced the Dacron graft. And then DeBakey, at that time, he was doing extra anatomical approaches for the repair as a way to limit ischemic insults, sort of in the late 50s, early 60s. Cooley then went back to end-to-end graft approaches to open repair, and Crawford sort of brought this all together with an occlusion approach, inline reconstruction, and then wrapping the graft with the aneurysm sac, and based on the work of Carrel, described anastomosing a small button of aorta around a renal artery to a hole in the graft, and this brought us to sort of the late 60s. Incorporating these anatomic in situ repairs, the inclusion technique, Carrel patches, and sequential clamping, and abandoning the aneurysmectomy, Crawford improved early survival to up to even 92% per reports, with very little sort of discernment of what exact type of aneurysm they were dealing with. Some adjuncts came on the scene as this was happening with extracorporeal circulation, which was heavily adopted by DeBakey and Cooley, but Crawford used a little bit of left heart bypass, but mostly preferred to clamp and sew. Then in the 80s, we started with the clinical use of cerebrospinal fluid drainage to try to prevent some of the spinal cord ischemia. This started with a failed randomized control trial, and then one of Crawford's acolytes performed a more aggressive drainage and even infused intrathecal papaverin and showed a benefit. Around the same time, people started using cold renal perfusion. Whoops. Oops. So what are the results of open repair? One of the problems with discussing this is that a lot of the papers don't really distinguish very well on their results between descending thoracic aneurysm repairs and true thoracoabdominal aneurysms, which are very different, as everybody knows, in terms of outcomes and complexity. So that being said, Estrella reported almost 2,000 patients, 310 of which were extent 2. Did not distinguish mortality between elective and non-elective cases, but mortality was up to 16%, with post-op dialysis occurring in 16%, and a permanent neurodeficit in 7%. Caselli performed nearly 3,100 patients, or reported upon them, nearly a third of which were extent 2. Mortality was 7.5%, with elective mortality only being at 6.2%. Post-op dialysis, whether or not it continued to discharge, was 7.6%, and permanent spinal cord deficit was about 5%. Giardi went on to present nearly 800 combined descending thoracic and thoracoabdominal aneurysms. Mortality was 5.6%, post-op dialysis 5.2%, and a cord deficit only in 2.6%. Carino then presented 112 thoracoabdominal aneurysms. Elective mortality was only 3.2%. Permanent paraplegia and stroke each came in at 2.6%, and 8% required some dialysis, whether or not this persisted to discharge. So what about the evolution of endovascular repair? A lot of the initial attempts were hybrid approaches, the idea being that you would avoid a thoracotomy and the single lung ventilation, you would avoid an aortic clamp and its attendant physiologic changes that a lot of these older, less healthy patients struggled with post-operatively. So looking at one study that actually that looked at 660 patients throughout 19 different studies, early mortality for this was actually quite high at 12.6%, which is not substantively different than the early results on open thoracoabdominal repair, and actually worse than the later results. Overall spinal cord ischemia was 3.5%. Overall perioperability was quite high at 35 to 61%. And the authors noted that visceral graft occlusion was disturbingly more common than anticipated, with truly disastrous consequences. So this is not a hugely popular approach at this point in time, but is not without its applications. So what about purely endo techniques like parallel grafting, PMEGs, and then off-the-shelf T-branch or TAMB type approaches. So there's a systematic review looking at 71 studies. They concluded that pure endo approaches compared to open approaches offered higher rates of spinal cord ischemia, but actually similar rates of permanent paralysis, lower rates of post-op dialysis, but similar rates of being discharged on dialysis, and a similar perioperative mortality to open repair. So what about the results of endo repair as reported by individual authors? So the Verhoeven study looked at endovascular thoracoabdominal repair and had an early mortality of 7.8%, which is not hugely different from more recent open thoraco results. Spinal cord ischemia of 9%. But what's truly remarkable about these studies is the reintervention rate, which was up to a quarter of the patients at 3 years. Another study looked at fenestrated and branched repairs for aneurysms resulting from degenerated type B dissections. These resulted in a 30-day mortality of only 3.2%, which on the whole offers an improvement over open repair, but in a startling reintervention rate of 60% at 31 months. Missing from this data, you'll notice the true long-term technical success. How many of these patients don't get reintervened on, but likely needed to be reintervened on, either because they failed to follow up, or because they really stopped being candidates for repair, or because they didn't have an endo solution and were not considered for open repair. So when the endo approach fails, what happens? These authors of the article in the middle here noted that when further endovascular repairs are unsuitable to address complications and failures, a relevant number of patients remain who require conventional open repair to fix it. In their experience, the time between TEVAR and open repair was 2.6 years. They found that open repair after TEVAR was associated with a higher morbidity and mortality than standard de novo open repairs. They attributed this to perigraft inflammation, which resulted in increased bleeding, adhesions, fistulas, and longer operative times. Our recent experience supports this. Here's some extensive graphs that we took out of a gentleman who had a degenerated type B dissection, which actually ruptured and had, I believe it was 3 endo attempts, including this candy plug, and ultimately required extirpation of most of it and open repair in a type 2 fashion. So we spent all of the money and then ended up open. So what happens in cases of endovascular failure, and does it happen? Oops. Open conversion. So what do the authors say when you read the literature? Open conversion of thoracoabdominal aortic disease after failed attempts of endovascular treatment is increasingly required today. Long-term durability of endovascular repair remains an open issue. Generally, a significant number of reinterventions are required over time, as we saw on the previous slide. Endograft durability may be being overestimated as age-related and comorbidity-related mortality can hide the impact of endovascular failure. And this is particularly important when you're thinking of pushing the envelope in younger patients in terms of endovascular approach. We don't know the true durability of these grafts because most of the patients themselves are not overly durable. As a consequence of the widespread use of endovascular repair, the number of patients requiring open conversion is growing. Open surgery after failed repair is much more challenging than in native aortas, with the technical issues of endovascular material removal and management of much more fragile vascular tissues. These factors contribute to the higher in-hospital mortality in these patients. Given the increased technical complexity and higher postoperative mortality after open conversion compared with native aortic surgery, the issue of long-term durability, physicians must carefully evaluate the relative benefits of endovascular procedures in young, fit patients who could otherwise tolerate open repair. Authors also point out that many patients who eventually undergo open conversion have already had multiple surgical or endovascular procedures to try to maintain an endo repair. Frequently, the open conversion represents the last hope for these patients who have already undergone repeated contrast administration for diagnostic or therapeutic procedures, which in turn is associated with the risk of acute renal injury and then chronic kidney disease, which, as everybody knows, is associated with worse downstream outcomes after an open repair. So what about a comparison? There is no head-to-head randomized controlled trial to compare endo and open repair, and one is not forthcoming. Overall, open repair is durable with better long-term outcomes, but cannot be tolerated by all patients. Endo repair is better tolerated in the short term with better perioperative survival, but an exceedingly large number of reinterventions and worsened long-term survival. So I conclude that endo solutions in the current iteration cannot wholly replace open thoracoabdominal aortic repair. Endo and open repair should actually be considered complementary options rather than competitive. Given the extremely high reintervention rate of open repair, younger, healthier patients should strongly be considered for open repair. For me, the persistent questions are around boundaries. Who should get an open repair and who endo? Who's the young patient who maybe isn't as healthy, who should get an endo repair and see what the longevity of the graft is? And what about the patients who shouldn't get a repair at all? Because even though you could have a perfect technical success endovascular, you're not actually improving their quality and duration of life. And then I added this short video just to show that really great and fun. So, but we can move on to the next one.
Okay, thank you, Dr. Bennett. That does look so fun. Thanks for that wonderful overview of the vascular surgery canon and really an eye-opening and provocative look at this complex aortic disease treatment and kind of the implications thereof. Uh, to kind of provide a counterpoint, we're going to move to Dr. Caputo. Dr. Caputo is a nationally known expert in aortic disease. Since 2018, he has been at the Cleveland Clinic, where he serves as the vascular surgery director for the Aortic Center, as well as the director of the vascular surgery training programs and a staff surgeon. He is going to talk to us today about personalizing aortic repairs. Dr. Caputa, take it away.
You would think after learning from the COVID that you know how to take the mute button off, but I guess you can't take the mute button off all the time. You still screw it up sometimes. But let me just I'll get there. Promise. Can you guys see my screen? All right, great. So, you know, Dr. Bath knows how much of an expert I am in endovascular repair of aortic surgery. So he gave me that I wouldn't want that incision, personalizing aortic repair by standardizing PMEGs with TrioFit. And I think this is appropriate because myself and Dr. Lyden were able to finally get an IDE after 2 years, and we thought we would talk about this a little bit. And I think I'm going to go into a little bit of a journey about how the IDE we got and why we got it, right? So here's my disclosures, but my real disclosure is my primary practice of aortic surgery is open in nature, and I want to segue that the previous talker, I agree 100% with everything she said. However, there's no doubt that there's a role for endovascular treatments in complicated aneurysms. You know, we should be working together to make therapies available for these individuals and not just those lucky to live near the white towers of the CMD centers. You know, when do I choose endovascular for complicated aneurysms? Well, you know, if the patient is morbidly obese, most recently I've been doing like telling people to go on Ozempic and stuff to help them lose some weight. But the reality is, if it's a large aneurysm, I kind of do talk to them. It's not a deal breaker, but I do consider wound infections, potential aortic complications. And you have to remember too, I mean, bowel complications is not uncommon in the connective tissue disorder population, particularly with diverticulitis or bowel perforation. So some of these patients do have ostomies and stuff. And when they put in, you know, you do have to have the potential, you know, you can close it off real quick with a little nylon and protect it from the wound. But the reality is there's no way you can't tell me that there's not increased contamination when you do these patients. So these are some of the things I think about, right? There are definitive deal breakers. You know, the pulmonary cripple, I think, is one of the hardest patients to deal with because it's not just the lungs you're dealing with, it's really with the whole cardiovascular response to the low oxygen. That they do pretty poor postoperatively. And you know, the difficult part is, you know, you always see these pictures of like grandma and grandpa sitting on the chair with their oxygen tanks. But the reality is, you know, a lot of these patients that are younger in our practice, and whether it's due to their severe pulmonary compromise from scoliosis, or whether it's from their severe heart disease of their connective tissue disorders, you know, they do have pulmonary and cardiovascular compromise at a very young age. You know, um, We have done some LVADs open, and let me tell you, it's much better to do it endovascular if you can, particularly when you have to deal with the drive lines and stuff. So why did we choose to go after the PMEG IDE? Well, first of all, CMD is not expanding, so it wasn't like they were knocking out the door saying, "Oh, we want you guys to get CMD." But the reality is, I do think that there is a place in PMEG, and for us to turn a blind eye across the country saying PNEG is not being done, I would suspect that it's being done very appropriately and very well in a lot of centers. But to do it without an IDE prevents research and really expanding the field. I mean, if you think about it, every time I throw on a left renal bypass onto a main Dacron graft, I'm modifying a device, and no one yells at me about that. And I can do all the research I want in the world on that. But I'm not here to argue whether PMAG should be done or not done. I'm just saying that if you really want to do it well, you should try to get an IDE. And PMAGs give you the versatility to treat unmet needs of patients in urgent situations, symptomatic, rapidly growing. And, a lot of times, you're waiting months for these ZFEN pluses, ZFEN, CMD. So it does give you the opportunity to treat patients, not that just that they can't be done open, but you can do them in an expeditious manner. But you got to really do it in a systematic approach to try to get this IDE, right? So you got to make sure you have the money to support the IDE. The money, it is not cheap to, and this was very eye-opening to me, how expensive it is to run an IDE, collect the resources, collect the money, and it is often topics upon topics at meetings. But this is something to think about. And make sure you have vested people in supporting the IDE. My department chair is actually the physician sponsor, so it was easy to convince him. But you also want to make sure you have the institute, because the last thing you want to do is start having running. And I've heard about these things from some of my colleagues that, after a year, do you know how much this IDE is costing us? Should we continue doing it? So you have to be prepared. And as you're applying, be prepared to talk to a lot of people about issues you never thought were issues, like what type of stitch you're going to sew your fenestration with. If I hear one more time about, what stent we're going to use, or what material we're going to use, or we're going to use the gooseneck snare or the gold snare. So these are things you never thought were a problem that people have problems with. But just remember, it's not just end there. It's a lot of data collection. It's a lot of work. And depending on the form, just to give an idea, this is just my pre-op forms. This is my baselines. I have over 17 forms pretty much to write up for a PMEG to submit the data. And so most of it's electronic now, but this is kind of what the forms are based on. Now we did base it just to give you an idea of the fenestrated trio device. Now this is not availably commercial. And this is not the PMEG, but this is kind of what the platform is going to be that we base it on. And just to give you an idea, the idea is just to be able to be a little bit more modifiable than your standard ZFENs, to be a little bit more personable and using the bifurcated devices. And this is kind of what it kind of looks like. This is their bifurcated graft, does offer advantages. It allows you to mobilize the neck in a distinct fashion and constrain it without needing necessarily to do provocative maneuvers. It does collapse on its own. And if you notice, it does come in significant lengths, 80, 100, 120, 140, which does allow you to think about breaking out into the thoracoabdominal world. And there's no doubt that much like a lot of the commercially available devices, there's an AP and lateral movement. But the one thing that you should look at is the robustness of the FEVARs. And I think this is, to me, the game changer of any type of PMEG or thoracoabdominal, is using the circumferential radial opacity. I know ZFEN Plus does it now. Trumo's going to do it on their commercial device, and I know for a fact on the PMEGs that's what we're going to do too. And to me personally, that makes a huge game changer. Not to everybody, but for my eyes, I guess I'm getting old. The circumferential radial opacity does make it a huge difference. But this is what our PMEG is based on. And to give you an idea of what we mean by personalized care, the trio fit is what we talk about when we come into play. And this is what it comes into. And it's position modification, templates, suture, and a suturing. So what does the template look like? That is the template that is personalized off of CAT scan, and then of course applying the suture and the suture rings. Just to give you an idea, the template is placed over. You mark your graft, you sew it, you burn it, and then you reload the graft. And the reloading of the graft has gone through several modifications, and we actually have now gotten away where we have a reloading tool. And Terumo is the only company that will provide you with a reloading tool for the PMEGs. Every time else, you're either using sutures, umbilical tape, Ramels, and there's 1,000 ways to do it, but they actually provide you with a reloading tool. So how are we going to do this? Now, supposedly this can all be done within 48 hours. Now, our IDE allows us to do it without the trio fit, but physician sends the CAT scans to the review. We engineer the proposed template, design based on aorta fit, agreed on design, templates manufactured, sterilized, and shipped to Phagen. Supposedly that can be all done from box to box in 48 hours. And to give you an idea of what they're looking at, is pretty much you're doing your 3D recons off of your CAT scans. You know, to go into the proprietary aorta fit, go back and forth on how to make the template. Here is a template with the arc lengths, the angles, and the clock faces, and providing you with the template. Manufacturing. Now, the one thing I did propose that did not go over well was, why don't you just give us the 3D printer? Why not just provide the printer for the centers? But that did not go over well. But I think that it has to be centralized and FDA proposed. But the reality is, I do think this is the space where if we are going to study PMEGs, I do think that CMD is really kind of not going to happen. I think in my talks with the FDA, they are not expanding that anytime soon. And getting this getting this IDE approved was literally 2 years in the making. And that's with some sophisticated people on our end, not me, but the people that have dealt with the IDE for a long time, putting it through. And I also think, like I mentioned, it makes no sense to me personally why I can modify a graft without a problem on an open patient, but the minute you start thinking about doing an endovascular, it becomes a whole new world. Now, it is a little more complicated than that, but in my mind, we're surgeons, we're trained to do this, and I do think that there are certain companies that are providing access to allow people to do this. I do think the role PMEG is real, and however, it's really understudied. I think the IDE is allowed to do that. I think Terumo is doing a great job, and I'm not sponsored by Terumo or I just believe in the company. I do think that the way they rolling out the IDE is great. I think we'll have better data with that. We'll have some form of consortiums with that. Companies are trying to make the things much more commercially available, and kudos, it should be. I mean, you have to remember, like, I was a graduate in 2010. 2012 was my fellowship, and we were doing CMD back then. So it's been 13 years, and there's been no rollout of this. And I think finally we're getting there. But we need to have off-the-shelf options, and kudos to Gore with the TAMBI for the thoracoabdominal devices. Kudos to Cook working with trying to get T-branch going. But I do think that we really have to work on this. I do want to thank Dr. Bath and Dr. Falls and CJ and everybody for letting me get involved, and always open to any questions.
Well, thank you. Thank you, everybody. Thank all the speakers tonight for their wonderful presentations. And we're running a little bit over time, but I think we still have ample time for questions and discussion. So we have a following question from the audience already. So a person is asking, for type B aortic dissection, do you have a limit of medications prior to saying that it is a medical failure? I guess this is going to be posed to Dr. Roundtree.
Awesome, and thank you. So it's not the number of medications, but really the time frame. So you've got about 12 hours to get them under control, so long as you don't have a patient who has imminent rupture, signs of end organ ischemia, including visceral legs or stroke. You're really looking at if you can get their heart rate down, their blood pressure controlled, and their pain controlled within 12 hours to call it a medical management success. Otherwise, you'd be exploring some of the other avenues, which I do strongly agree with. Again, thank you, Dr. Bath, for giving me the medical management option here.
So in lieu of that, I want to ask a follow-up question. So when do you make the call on an uncomplicated type B dissection to operate or to intervene? Outside of conversion, outside of conversion into the the complicated stage. So when do you make the call?
So personally, and again, it was an interesting thing for Dr. Bath asked me to ask to take the medical management stance because it's definitely the unsexy option, if you will, in that vernacular. That for me, it's looking at it of can we get them out of the acute phase into the subacute phase? What's the overall holistic approach to the patient? Is this someone who's older, frailer? Am I going to give them a long-term benefit by actually intervening on them, potentially with a TVAR or sealing that entry tear? Also looking at the specific anatomy of them. Once they're on medical management, getting them past the 2-week point to decrease the risk of conversion to a type A. Do they have the anatomy that can actually be sealed? Or am I going to achieve a thoracic? Um, that's fine. I'm looking at the questions. Am I going to achieve a thoracic remodeling and still leave them with that abdominal potential for expansion with either a sign or another residual tear distally?
Very good.
Okay. I do have one more follow-up question to that. So we are seeing a number of young patients in their 40s, 50s coming in with drug use on board. Does that sway your decision whether or not to treat these patients? Anecdotally, you hear about, well, we don't know if this patient's going to follow up, so we'll just throw a stent in there and, hope for the best. What are your thoughts on that?
And my personal thoughts on that one, it's twofold. Is if we have someone who has a drug abuse history, they are a younger person, they should have overall a longer longevity on them. The other concern, though, is you're putting in a prosthetic. You're putting in something that can be temporarily bacteremic from any choice of insert or needle choice here, and then seated. Actually, I am in a rural hospital, and I'm kind of embracing that currently. I just moved down from the Detroit area. I had the pleasure of actually being a colleague of Dr. Kabani. And I'm seeing a lot more 28-year-olds who are newly found HIV positive, have IV drug use. I just transferred out a dissection patient myself up to St. Louis who was complicated with end organ ischemia. And the question is, how are they going to benefit from which intervention with knowing they're probably going to be bacteremic again in the near future?
I want to ask a question to Lloyd. Dr. Kabani, you propose that the traditional sort of paradigm for management of complicated or uncomplicated type B dissection is to cover the entry tear and be done. So we have multiple other adjuncts and other philosophies now in managing the whole of the type B aortic dissection. So what is your approach, and when do you call for the petticoat or other systems, or do you intervene on the whole aorta at the time of making the call to treat it?
So I guess the first question is when do you treat? And like Dr. Roundtree said, and I think everybody's in agreement, there's a subset of patients, you don't want to treat everybody. There's a subset of patients that are going to do very well with medical therapy. I think we all agree on that point. But I think there's also a subset of patients that if we treat early, we can probably decrease the risk of them having a more complex operation down the road. And that subset is still being discovered and still being targeted, and we don't know who they are. I think if you have rapid growth, that would be something very easily. If you have good so when you look at somebody, there's several things. You need to make sure that they're good operative candidate, right? Somebody who's 90 years old and has a dissection that goes up into the arch, and you're going to have to do a carotid subclavian bypass to get a proximal seal, and it's not enlarging very well. That's probably not somebody you want to treat endovascularly. You probably want to treat medically. But if you have somebody that is in the reasonably aged, then I would say probably in the 50s or 60s, has a good entry tear, that you can cover without covering the subclavian artery, and the dissection doesn't go all the way down to the celiac, and has manifestation of rapid growth or pleural effusion or one of the higher risk factors, and you know that they are high risk of growing and developing an aneurysm and potentially rupturing, and it's a simple fix, and you want to fix those patients early on. So it's a wide pendulum, different patients, and each one is individualized. I think everybody would agree. Every dissection patient is a little different than the other one, and everybody has their own little thing. And you have to have a big discussion with the patients. We're enrolling for the Improve AD, and I really believe there's equipoise. When you come to these patients, you need to. I think we don't know. And hopefully with the Improve AD data, we're going to have a little bit more clearer discussion with the patients of who can benefit from this technology. To finish up, one last thing is are we going to get rid of all the type 1B? So you finish up the intertear and you know you have multiple intertears distally that you're not going to cover. Are you making those patients better? I think if you get thrombosis of thoracic aorta, I think you do. But like we showed in our paper that we present to Midwest Vascular, if you can't get thrombosis of the thoracic aorta and you still have contrast going from the distal intertears all the way up, those patients are not going to do well.
Very good.
Okay.
Sorry, to follow up on that, specifically, the audience is also asking, technologies such as the petticoat that's been out. When do you use it? What's your criteria for using?
So the petticoat, the data for the petticoat shows there's increase. It helps the aortic remodeling. There's no data that shows it decreases aneurysmal growth. And that makes sense to me because you're not sealing the intertear. So the time I use the petticoat is you have malperfusion. I think it's an excellent tool if you have malperfusion of the visceral vessels after you cover the intertear. Other than that, I don't think it should be used routinely. And I'd be interested in Frank and the other panelists. If you have to operate on people with petticoat, I think it makes your operation more complex. I know, Kyle, Frank, what do you think? And Caitlin?
Well, Frank had to go to the OR,
Okay.
so he's gone. Um,
In my experience, actually, it doesn't make a PMEG that if you need to do it for a degenerative situation of the thoracoabdominal aorta to have a petticoat in place. I think the fenestrations or the cage, structure on the device is large enough for you to go ahead and PMEG through that if you need to. So in the endovascular side, I don't see it, and I'll also oftentimes have to stent through a petticoat to open up a renal because there's a competing dissection flap into a visceral artery, and the petticoat itself has not obstructed that particular situation or an endovascular approach. Not sure about the open, and I'm guessing if you look at the petticoat, it's a very fragile stent or very compliant stent. So I don't think that it'd be a big issue in removing that if you had to do a traditional open approach after a dissection.
okay.
Do you use it routinely, CJ?
What was that?
Use
I
petticoat?
do use it routinely because oftentimes if I see a very compressed true lumen, I do think that especially in the younger population, they benefit from relaminating that delaminated intima earlier. And there is a very positive aortic remodeling that I do see. And I do think that it does help with a lot of the 1Bs or other situations that you run into as that aorta continues to degenerate. So if you relaminate that intima, in my opinion, at least in the short experience that I have, maybe in the last 5 years, I've been using it more routinely. I see that there's some positive effect. Again, with anything that we're discussing today, I don't think we've really moved the mortality dial much, but it looks pretty on CT scans.
I couldn't resist that meme on the start of my presentation.
Dr. Bennett, are you still on with us?
I'm here.
Oh, hey, I had one more question for you on this last minute. People are coming in and they're a lot more educated than they were in the past. Dr. Google kind of informs a lot of our patients, and some of them feel that minimally invasive surgery, no matter what it is much better for them, less downtime or whatnot. How do you approach these patients with, you need this big operation to repair this type 3, type 4 thoracoabdominal, and in this kind of age of, selling the minimally invasive approach to everyone?
Yeah, it depends who they are and what I think they'll benefit from, but I usually have a pretty frank discussion about, exactly what I sort of focused on here, which is the reintervention rate. And a lot of patients are really turned off by the minimally invasive when they hear, we've got to get all these scans. There's, at least there's probably a 50% chance you'll need another procedure at some point, and then another one after that. And so usually you can steer them into what you think is best without being overly patronizing by telling them, what you know of them as what you've learned about them and their lifestyle, and whether you think that is something where they're going to want to come back all the time for more stuff and possibly have an unstable or non-repair if it becomes unstable. And so I talk to them pretty honestly about that, especially in the setting where there's a lot of potential sources of endo leaks, or the anatomy and angles are such that you foresee steel issues.
Mhm. Okay.
Questions from the audience? Well, I think we'll wrap it up here. It's a little over 7 o'clock, and I really want to thank everybody, the panelists, especially the speakers today, for the wonderful talks, and again, our society for supporting this endeavor, as well as Terumo for supporting this webinar. So thank you, everybody, and have a good night.
Thank you very much.